Welcome, everyone. We're going to have our panelists join in just a bit. Right. So first, I want to welcome you to Pandemic Reflections. It's an engaging panel event hosted by the Student National Medical Association's Health Policy and Legislative Affairs Committee. My name is Kelly Butler, and I'm a fourth-year medical student at the University of California, Irvine. And within the HPLA, our committee, I've served as both a fellow and a general committee member. This work is personal and important to me in a lot of ways. I am beyond hyped to be joined by such powerhouses this evening. So let me introduce them. First is Dr. Yvette Calderon. She's the chair of emergency medicine at Mount Sinai Beth Israel Hospital. Thus, she was on the front lines of the nation's first big COVID-19 hotspot. Previously to tackling COVID-19, she's worked for decades to address health disparities in New York City through research. Welcome, Dr. Calderon. Second is Dr. Cynthia Annanoby. She's a pulmonary and critical care fellow at the University of Miami Jackson Health, working directly with COVID-19 patients since March in Georgia and Florida. Welcome, Dr. Annanoby. Next up is Dr. Kwanzaa Pinckney. She's an emergency physician and medical director for CHI St. Luke's Sugar Land Hospital. She's been treating and educating the public about COVID-19 since the beginning of the pandemic. Welcome, Dr. Pinckney. And last but not least is Dr. Enyeko Tugo. She's an emergency medicine physician at Brigham and Women's Hospital and a health policy fellow with an interest in racial health disparities and access to care issues. Welcome, Dr. Tugo. So I first just want to offer some housekeeping points. To our participants who are joining us tonight, ask plenty of questions. I have my own, but take advantage of this knowledge powerhouse that is joining me on this panel tonight. Use the chat box if you have any other questions or points of conversation. And as they come in, our team will highlight them both on our screen and verbally to engage our patients, our panelists around what you all have to say. Second, feel free to air grievances. This is your time to decompress and reflect, just as it is for our panelists. Third, please be mindful of language. We aim to always create open yet safe spaces for dialogue, and language matters. And lastly, if you have questions about the Health Policy and Legislative Affairs Committee within the SNMA, follow up with us at healthpolicy@snma.org. So my first question for all four of our panelists today, I first just want to check in. It's a lot right now. And so if you could offer 3 words or a brief phrase about your mood today, all things considered, what would it be? I can start with Dr. Otugo.
I guess the word I would use is perseverance. There's a lot going on, however, still able to trying to stay afloat of everything that's been going on as well, so.
Sure. And Dr. Calderon?
I think the 2 words that really are kind of come up first for me is being grateful. So, the gratitude of being with a great team that I have at Mount Sinai Beth Israel and working there. They're powerhouses, and just like everyone here, I'm sure your teams are just equally as wonderful. I think the other word that comes up is resilience, because during this time, I think that there's nothing but resilience that we rely on. And emergency medicine docs typically do rely a lot on that. So those are the 2 words that come to mind.
Sure. Dr. Annanoby.
Oh, they took my words. But one of them for sure will be resilience. This has been a very long pandemic, longer than I think a lot of us expected. So resilience is definitely a very big word for me that signifies kind of my attitude throughout this whole thing. Another one would probably be growth. I think a lot of growth and our knowledge and our ability to kind of fight this pandemic has occurred as well. And then another one would be attitude. I think your attitude throughout this pandemic has affected a lot of our ability to keep persevering and keep pushing forward despite some of the things that we've seen.
Sure. And Dr. Pinckney.
Ooh, y'all all said really great things. I'm gonna go with perseverance. It's been a long year. All of our teams are tired. Staff is tired. EMS is tired. The patients are sick. They're tired. And so, maneuvering through that, managing that, and then my second word would be pushed, is that we have to continue to push forward despite these challenges. Oh, I had three. And flexibility. You have to learn how to be flexible and nimble very quickly in this environment because it's very quickly changing.
Absolutely. And so I think a common theme in what you all started to point on and how you had to find some sort of resilience, wellness, positivity, in especially acknowledging the length of this pandemic. So I wonder if we can bring our minds back to a January, February 2020, right? When this was very new, we didn't have the knowledge that we do now. This wasn't necessarily covered by media in the way that it has been. What was that moment that you knew this pandemic was real? When you knew that your day-to-day, how you came into work every day, how you would have to find these elements of resilience and being flexible in your work schedule. What was that moment for you? We can start with Dr. Calderon.
Well, I think the real moment for me that I knew that not only was this disease real, but it was in our backyard. I got a call on a weekend from one of my faculty who was in urgent care, and she said, Yvette, I have a patient here from Wuhan who's complaining of all these symptoms, but he doesn't fit the criteria for testing from the Department of Health. And I thought to myself, oh my God, this is just going to be the beginning. That was really that moment of a realization that we had to hunker down and start thinking about how to protect our faculty, our nurses, everyone that was working in the emergency departments, and the other, patients that were in the emergency department. How are we going to kind of think through the redesign of our ED? So yeah, that was a very surreal moment.
I can only imagine. Can we imagine for our participants getting that first phone call if I have a patient in the ED from Wuhan? My goodness. I wonder also about your experience in emergency settings, Dr. Tugo. When was that moment for you?
Yeah, I think just kind of seeing the different policies change day to day. We're still trying to figure out what was going on and how this would affect patients and who was actually getting tested. And then in addition to that, seeing what specialties or specialists would actually come down to the emergency department. A lot of people were afraid. We didn't know what was going on, and we could kind of see that kind of reverberate throughout the entire hospital. So, yeah.
I think that fear point is really necessary for us to highlight, because some people think that as providers, we were completely blind or unable to express that fear as the general public would, that we just strongly walked onto the front lines as if nothing, could affect us. And that's so far from the truth. Even now, I'm in emergency medicine rotation right now, and I asked for a plastics fellow to come and repair a lac on someone's face. And they're like, well, have they been tested yet? What symptoms, right? Like that fear still exists. I wonder if you felt some of that same fear in the ICU, Dr. Annanoby.
Definitely.
Yeah.
So working in ICU, it's a little different from, I guess, the emergency part of it, because y'all see them, the emergency doctors see them like immediately first when they first come in. But definitely, so right now, like you said, I'm a fellow in Miami, but before I was a resident in Georgia. And so at that time I was just a resident, and I really didn't know what to expect. And I remember my program sending an email saying that the internal medicine residents would be the first ones to be pulled into the ICU COVID unit. And I remember my name was the first one there. And I was like, oh my God, what? I'm the first one to be covering. And I remember telling my mother, and she was terrified. She was online trying to order hazmat suits and respirators and just kind of trying to figure out how to make sure I was best safe. So there's definitely a lot of fear, but I think through the pandemic, and at that time was where I really kind of stepped up to the plate and realized, like, this is kind of like our duty. This is a time to kind of step up as a physician, as a leader within the hospital. And that fear just kind of took a back seat to just what I needed to do.
Sure, it had to, right? We had to put that fear behind us. I wonder for you, Dr. Pinckney, what was that defining moment that you were like, yeah, we're here, this is real?
Oh, wow. Yeah. So, gosh, I remember it just like it was yesterday. So I want to say January, February, we had just started doing a lot of education with the staff and just really, coming to speed with what was really going on in real time in Wuhan. And then in March, we got our first patient. And it was the moment I knew it was going to be off the chain is in talking to this patient, understanding and realizing that this person had traveled and he had not actually traveled with the person who infected him or, exposed him to COVID. And so I remember I just kept asking him over and over. I was like, so you didn't travel with this person? He was like, no. And I was like, so you didn't ride nowhere with this person? Like, how close were you? And he was like, I have no idea who this person is. It just had to be like a casual encounter. And then seeing the level of hypoxia or low oxygen that he had, and seeing his CAT scan findings, which of course, has become the norm now. I think it was at that point that I realized like, whoa, this is about to be off the chain. And then it was.
I want to come back to that point around how you had to step up. You didn't really have the option of not.
Mm-hmm.
And I want to bring this question back to you, Dr. Pinckney, and you as well, Dr. Calderon. You both occupy labeled leadership roles. And I say labeled because we're all leaders in our respective ways, but carrying, the medical director title, it comes with a certain set of responsibility to figure out how people were going to possibly navigate this very, very new stressor on the system. And so I wonder how, in your roles, did this pandemic make you think differently about yourself as a physician leader and what your role is to steer change in clinical settings? So I can come back to you, Dr. Pinckney.
Sure. I think for me, COVID's been a mixed bag, So on one hand, I'm an ED director. I'm also newly vice chief of staff. So it was like game time. And so I would say the learning curve for what I've learned through, administrative policy, what it takes to really create a task force team, really relying on the relationships that we've built with other departments, like pulmonary critical care. That's like our backbone. Like, we're thick as thieves in that camp. And then also relaying the challenges to our administration to say, hey, we need to address X, Y, and Z so that our staff and our physicians are safe, getting adequate supplies. And everybody has to remember that, like, we've never dealt with this before. We all deal with the flu, we all deal with all kinds of things, but this is like a brand new thing. It's a whole new behavioral change, a cultural change that had to be instituted from the top down. Some things got done right, some things, could be better, but, I think it forces us all to step up and lead if you're going to lead and be there. So it's basically like on call 24/7. There's always something happening, always something shifting, always something adjusting protocols, learning new strategies to get people home faster, whether it's, setting up Homo 2 or whatever you can do to, help improve the efficiency and the quality and safety of the patients while they're with you. And then also manage your own stress and fatigue. And that's been quite a bit, but it's also rewarding. I would say in our specialty, as our ear docs know, and especially critical care know, we don't have the option to step away and, ask for a COVID screen before we see someone. And, that's sort of the flashpoint and danger point that we experience is that, it could be your knee, it could be, a slip and fall and it's your knee, but you might also have COVID. And that's what we started finding over and over again. You got fling pain, but you also got COVID because we can see it at the bottom of your skin. So I think for leadership, it definitely presented an opportunity for you to step up if you wanted to do that.
Absolutely. And I'd love to bring that question to you, Dr. Calderon, in your role. How did this stressor make you feel differently in your role in leadership?
Well, I think that as the chair of the department, I have the responsibility of everyone in my department. And, what I relied on was really the way I lead, which is a team approach. I want to echo what Dr. Pinckney said. It's a 24/7 job and has been since, March. Even though we're on call, we're there for our faculty. This was a very different time. It really felt like we were under siege. And it was, I was very lucky that, and again, I'll say this, and it's because we're a field that's all about teamwork. And I had a great team of two medical directors, one for pediatrics, one for adult. And we just would go in every day and round every day, several times a day. And exactly what Dr. Pinckney said, you would have to figure out, okay, what's the new change in the protocol? And be able to get this communication out to the faculty, to the nursing staff. It was really trying. I mean, it was, and then it was very surreal because you had this peak of incredible amount of patients coming in. And then all of a sudden, no one was coming in. And it was like, okay. It was scary as a specialty because when patients decided they were too scared to come to the ED, and the revenue and the patient flow was not coming into the hospitals, the financial implications of that became very real.
And I don't think we can divorce this conversation from finances. We can't divorce this conversation around reflections from the various isms around classism and racism in terms of access to care for reasons that were or were not related to COVID. So thank you for bringing that up. I wanted to ask you, Dr. Annanoby, as a trainee, in reassessing how you were moving through your training experience as a fellow and similarly as a resident in the beginning of the pandemic, what are some things that your hospital did well? What did they get right?
I would say actually both of my hospitals did really well in preparation prior to. We were fortunate enough I was fortunate enough to be at hospitals that weren't hit immediately pretty hard, but eventually, we got hit. But initially we saw surrounding hospitals being very much affected. And so at that time, our administration started putting things into play very quickly. I never ran out of PPE. And that was my biggest thing. I was ready to serve, ready to do anything that I need to do as long as I had proper PPE. And I never had an issue with that. And then another thing was like the emails that went out almost immediately. Change, like, because I was in ICU, of course, they started sending us, looks like I got frozen a little bit. Oh, sorry. But they immediately started sending out emails pertaining to which sectors of the hospital would change to COVID ICUs when the main ICU was overfilled. And they also let us know which residents or what teams, what specialties will be taking care of those units. So it was very organized overall. And then also just kind of learning about PPE, donning and doffing. We went through that training very early, proper hygiene and different things to kind of control infection spread when we got hit. So the time when we really did get affected, we were able to really combat it kind of fully, with full force.
There are really three really important themes there. First, proper messaging. You knew it was happening, you knew when it was happening, and you were learning things as the administration was. Two, a reasonable supply chain around PPE. And three, being adequately trained to use that PPE. It's important. For you, Dr. Tugo, in Boston, I know that it was a really interesting place because adjacent to some of the earlier hotspots, but far enough away that you might not have caught it in the same way that a New York did. What are some things that your hospital system got right?
I guess one of the things that they got right was kind of responding to the new information as they were getting it. And then eventually, when they started to see a lot of the racial disparities kind of coming out in testing, they kind of responded to that by kind of increasing testing in underserved communities.
And that's exactly what I wanted to bring us to next. Earlier I mentioned how you can't really divorce this conversation about COVID from racial disparities and health disparities. Some of you are well-versed and publicized in this space. And so I wanted to bring that back to you, Dr. Tugo, around what you witnessed in terms of the differential brunt or burden that was placed on certain communities. Did you witness that, or was that only really seen in the numbers and the statistics? Did you witness that your Black and brown patients may have been suffering in ways that they weren't, that you weren't finding in your white patients, for example?
Yeah, definitely. Most of the patients I was seeing dying initially were Black and brown people, unfortunately. And as a result, or kind of because of that, we also found out that a lot of Black and brown people weren't getting tested. So how do they know if they have the disease or not? How do they know whether or not to quarantine? Can they safely quarantine, kind of given their communities? So we kind of saw how all these issues were kind of compounding in a lot of these underserved areas, as well as minority populations. In addition, there's like also this thing called the crisis standards of care, which kind of like determines how critical resources such as ventilators would be distributed in a kind of a situation like what happened in New York when you basically overwhelm your hospital resources. We kind of found out that they're also using comorbid conditions, which also affect Black and brown communities. So they would probably be less likely to get these ventilators if they needed them. So we kind of started a lot of physician and community advocacy around that as well, in addition to making sure that they were getting tested in these areas. So.
And I want to offer the similar question to the rest of our panelists. If you have something to offer about how those disparities might have played out in front of you from a clinical care standpoint, I offer that here.
I mean, I would definitely say it's interesting because I think I was on a panel at the beginning of COVID, and what we talked about at that time was, resource is going to be your biggest predictor of long-term mortality. Your ability to get to a hospital early, your ability to get a ventilator, your ability to be in a system that's not yet overwhelmed will give you your best opportunity to survive well. One thing I would say, we take all comers. I never saw a problem in terms of, managing patients in the department. What we do see is upon discharge, as the hospital capacity grows, there's a push to drive patients out, right? They have to go somewhere at some point. And if you don't have, adequate funding, you don't have insurance, you don't have resources, you find yourself at a group home where someone, if you don't have an advocate, you're at their mercy, basically. And so for a lot of patients, their long-term prognosis due to comorbidities of race, class, finances will impact them, and for a very long time. And I think, the data will show with the long haulers or those who have COVID symptoms well past their initial infection and primary hospitalization have lingered, almost a year out. And I think that was, probably the message that we preached the most heavily in the beginning is like, if you're in an area that has a low capacity for hospital resources, it is not in your best interest to get infected with COVID. It's a problem. And I think a lot of people do not understand the way in which, to echo Dr. Calderon, declining hospital volumes, and then surges is like horrible on a hospital system as a whole. And we're all seeing it now. And what it ends up translates to is longer wait times, longer hospital admission times, increased mortality, and especially in communities at greatest risk. Now we're going to start to see the issue, in areas that weren't, seeing it before. There's not adequate resourcing or resources to meet the demand. And that triage process, unfortunately, may come into view in terms of, looking at sick, not sick, and making treatment protocol decisions based upon that. It is here upon us now.
Absolutely. And so, Dr. Calderon, I know you're well published in the HIV infectious disease kind of intersection with the emergency room and the emergency department. I wonder if you can put on your academic hat for a second and think about how the academic community may respond to these stories, right? Because we as providers, as future physicians, we have this ability to tap into lived experience when we talk about these issues, rather than just X population has demonstrated X positivity rate, etc. So I wonder how the academic community can better respond to some of these lived experience stories and better tell the story around this pandemic. A lot of us might rely on the literature to make decisions, to really develop our evidence base about how to treat these communities in a more culturally sensitive and humble way. How do you think, what do you think academia's role is in telling this story?
Well, more than academia, I think it's every specialty's role right now in actually starting to look at our practices in terms of health disparities. I think that's the place where most of the people that I work with and who are researchers have put their efforts into. I mean, it was clear, in New York that people that could leave to go to Long Island and had their homes there and they could work from home, we didn't see those patients. We saw patients that were essential workers coming in. We actually did geomapping pretty early on because it was clear to us who we were seeing. And yeah, it was the Black and brown patients who are essential workers who lived in multi-generational homes, and they had no way of quarantining themselves. We saw families come in and families with devastational losses, okay? And so I think that changed the community in general at Sinai to say, we got to stop and take action now. It's no longer good enough to say the IOM report, from 2002, great. Well, now we know that. We know that in spades. Now we have to do something. And I think my feeling is that as a specialty in emergency medicine, we're primed to look at so much of the health gaps that come through our door. And we're not, without culpability in terms of, how we practice emergency medicine. And I think we all need to start looking at that. And I know that there are a lot of departments right now in Sinai, OB being one of them, that have decided that in their dashboard, they would have equity metrics. So that as they report their metrics that they are graded on by the hospital, you're also reporting the equity metrics. So it's stratified by, race, ethnicity, and other cofactors that you may think influence the way a patient is being treated. So if that makes any sense, I think it's a bit of, joining the research world with the clinical administrative world and saying, let's put our, heads together and let's look at how we can actually unfold where the gaps are and then really drill down and make sure that we're doing right by our patients.
So you started to answer some of Isaac's question here. One of our participants in the chat box, they asked us, from what you all have witnessed, based on your lived experiences and your stories, let's think about solutions. How can the medical community transform to better address these faults, to better address these disparities, especially those involving race? I'd love to come to you first, Dr. Annanoby.
That's a good question. I think the biggest thing is to kind of learn from our mistakes so far. One of the things that we've noticed, we've already known that racial disparities has existed for ages. I think as we continue to increase the number of diverse physicians, Black and brown men, women, we need to better educate our patients because there is a lot of mistrust in the medical community, but I think the more that they see kind of younger doctors coming out who really care and are trying to educate the masses, the more they'll listen. So just kind of being at the forefront of educating our patients and not just kind of doing this step-by-step process and then sending them home. Another thing is, it kind of goes back to education as well, but just making sure that we let patients know about personal hygiene, how to better take care of themselves, take care of their family members, and not to fear the medical community. Most of our patients that I saw would just stay at home and wait for weeks, days and weeks while they were ill, infecting other people in their household before they would come into the hospital and be diagnosed with COVID. So by the time they came in, even with the racial disparities that existed, the fact that they waited so long and they were so sick led to an early demise that probably could have been prevented. I don't know. So just letting the patients know that we're here for them and kind of trying to help them in any way that we can.
Sure.
That would be my thing.
So I'm hearing the theme of like better arming your kind of personal responsibility toolbox, right? If we can better inform our patients in our communities, then they can make more, informed decisions, potentially safer decisions. And I think there's a lot to unpack about the balance between, kind of government oversight and official messaging and personal responsibility, especially in this pandemic. You could argue that, yes, there is a lot of tis poo on you because you didn't wear your mask at the airport, but there's also, the lack of messaging and incentive coming from federal government to stay home, right? So I think that's absolutely a really important balance to highlight. If we're thinking about solutions, I want to come to you, next, Dr. Pinckney. What do you think are some of the things that we can do to overcome some of what we've seen, some of what you witnessed, some of what you highlighted in your first answer around disparities?
You know what? I'm gonna call us on out. I think for those of us in leadership, it's time to start pushing the envelope. And I know that we've been working very hard to have these conversations, to drive these narratives, and to say what are we gonna do differently. Ironically, we're reading in our department's kind of book club, journal club, and epidemic of empathy. And I think the concept that resonated the most with me is building a team around your patient. And one of the biggest things that drops off in terms of managing a patient in a long-term way, meaning like it's going to create their best long-term survival with the best quality of life possible, is addressing their housing, addressing, their ability to get nutrition counseling, helping, dedicated social work, dedicated case management. Those are the things that we really are lacking tremendously. And really, when we look at, long-term about what happens when people go home, affects their ability to get back to the vibrancy of life. And two, we have to start forcing our administrations to look at this data, look at the information, educate our patients in a way that they can understand, whether it's, getting an interpreter on the line and then having the conversation with the whole family about how best to quarantine given your unique situation of having two families in your household. And so people in some ways have to get off their judgy soapbox and start really talking about the things that are happening in people's lives and addressing those things without judgment and saying, this is how people are living, this is the situation, and how can we serve them better? And then just pushing education as much as we can, across all platforms, and even, if it necessitates going to communities where, maybe they're not online, maybe they're not, watching the news, addressing those communities where they are.
Yeah. And I actually want to pose a question to all of our participants. Drop in the chat box or the comment box, where do you get your news about this stuff? Do you rely on your physician? Are you a social media, Twitter kind of girl? Are you on some sort of, media platform like an ABC, CNN, NBC, etc.? I'm curious, where you all get your news? And as we come to accept some of those answers, Dr. Tugo, I wanted to come to you. You're knee deep in a fellowship around these solutions, right? And so I wonder what your thought is around what we're supposed to do. What are we supposed to do, and especially from a policy standpoint? Just like I was saying, that balance between personal responsibility, better educating our patients, and that kind of top down from a policy standpoint. What is your thought there?
I think the key thing here is like having partnerships between physicians as well as the community, and having physician leaders that amplify the lived experiences of those in these communities. Oftentimes there's like this dissonance between our patients and our physicians, and that's oftentimes because our physicians do not look like the patients we're serving. So that also kind of goes into like increasing physician diversity. It's 2021. There's no reason for our emergency department physicians or any physicians to not look like the populations that they serve. So it's kind of two things: making sure that we partner with these communities and advocate for them, in addition to making sure that our physicians are supported and also are able to basically enhance the lives and health of the patients and populations that we serve. So, yeah.
Dr. Tugo, you spoke on a really interesting point around just kind of speaking truth to power, how those who are in power, who occupy positions of power, have to step up. I think Dr. Pinckney similarly tapped on that theme as well. So then the question comes to you, Dr. Calderon, as a chair. Do you feel like you even have the flexibility or ability as a woman of color to be that change agent? Or do you feel like you're working in a system that quiets or subdues your ability to effectuate change in the way that all of our panelists have outlined?
Let me say it this way. First of all, I do think I can be a change agent. I think all of us can be. You just have to figure out the way that you want to go out there and spread the word and how you're going to change things. I spent most of my career mentoring kids, trying to get kids into medical school, increasing that pipeline. And now I'm spending a lot of time as a chair making sure that individuals of color get onto leadership roles. We need to be there. We need to be at the table, or there's no way we are going to change the way things happen. So I do think there is a way of doing this. I think that faculty of color can come together in a health system and figure out the ways that are more important to them. You know, triage, what are the topics and the issues that we can change? I absolutely agree with partnering. Dr. Tugo is absolutely correct that, you know, the emergency department, we can make relationships with the community and with the Department of Health. You know, we can actually influence through gathering our data and making sure that when things are not being done correctly, that we talk about it honestly and openly. I think it's difficult in any large corporation to be able to do everything. But I also think where there's a margin, there's a mission that you can have. I very much believe that. I do want to bring up one other thing, though, and I think it's been touched upon, but I really want to say it out loud. You know, in addition to the social determinants of health, this idea of how we as physicians and nurses and just providers in general take care of our patients is really important. None of us are divorced from, you know, having our own biases, and we need to keep that in check, right? We need to look at that. And I don't have an answer for this of how to do it, but I do know we need to do it because I do believe, and there's much in the literature on this, that the biases that we have towards patients, whether it's because of their skin color or because, you know, of one of their comorbidities, will dictate the outcome of their healthcare. It just does. And I think this is something that we really need to spend a lot of time on.
So let's stay there for a second. I really encourage everyone to take Harvard's implicit bias test. It's the IAT, and it's a really interesting association test that can help highlight some of those internal biases that you all may harbor as our participants and even panelists. But I want to come back to this idea around how representation may put some of those biases at bay or maybe make them a little less harmful, right? But yes, all of us on this panel carry biases, but I think we're going to all look at that woman in pain and think a little bit differently around her pain than, say, someone that is male identifying would. Maybe as people of color, we see ourselves in that little old lady that says, you know, baby, my chest hurt. I'm going to have a different interaction with her than is my white male counterpart, right? And so I want to unpack this idea of representation. I know this is a COVID reflections panel, but I just want to touch on that because a couple of us have mentioned it. A question from our audience came from the Force for Health, highlighting that saying the Force for Health. I love seeing this diverse, beautiful panel with us today. The question reads, what would you say to middle school and high school students to possibly follow health profession pathways? How do we increase that representation? What would you say to that high schooler or middle schooler? How about you, Dr. Pinckney?
I'm gonna tend to just be 100. I don't think I sugarcoat what it is to be a physician, but I also don't shy away from the tremendous joy and love I have for the profession. I mean, our work has its challenges. It's stressful. It's a lot of time away from family and friends, a lot of sacrifice. But at the end of the day, I call them good doctor days. When I have one, it is transformative, and it can make up for 3 bad months of just like chaos. So, you know, the really precious gift that we have to treat and serve really has to be at the core of your desire, I would say. And if you have that, and then you have the want and the support and the ability to see it through, the sky's the limit. Honestly, there's nothing else I could see myself doing, even as crazy as things are right now, and things have been, situations, policies, bureaucracy. I wouldn't have it any other way. I love being a doctor. And I would just say, you know, make sure to do your due diligence, make sure that, you know, you spend time with mentors in a field that you're interested in, so that you can get a better look at about what medicine looks like in real life, because it's a far different thing than, you know, Grey's Anatomy. And so we are. It's just a different ballgame. It's just a different beast, but it's still a very rewarding career. And as you come through, you'll learn about the different aspects of it. You know, resources, economics, all that sort of stuff comes in time. But you know, I think the service of patients, there's nothing more honorable, and I'm grateful to be a part of this team.
Absolutely. And so to recap, know what you're getting into, and you can figure out what you're getting into by talking to people who are doing it. If I could just summarize some of those points. Dr. Annanoby, what would you tell the middle schooler or high schooler that might be thinking about a health profession, especially in a time like this one?
I would say do it. I think, kind of to piggyback off of Dr. Pinckney, was that the biggest thing is to find a mentor. Growing up, I try to think back and I try to realize, like, I really didn't see a lot of young, diverse, you know, doctors growing up. But now there's so many of us. I have my social media page on Instagram, and I mean, there's hundreds of Black, brown women physicians who are constantly advocating, constantly open for mentoring, constantly providing information for the younger generation coming up. And we have definitely developed a culture of trying to, you know, grab the younger ones and kind of bring them up with us. So I think the biggest thing is, you know, everybody has a smartphone. Almost, I mean, I actually believe everybody has a smartphone these days. Especially like our young people. So the same way that they're on, you know, Instagram and Facebook and Twitter, you know, tweeting away, is the same way they can look for these resources. And don't be shy. Go into someone's inbox, write a DM, write a personal message, and just, you know, talk about your interests and look for mentorship, because it's doable. I piggyback off what Dr. Pinckney said, and I love medicine. I think that this was the field that I was destined to be in. I'm happy, and even on the toughest days, I still find some type of joy in the field. So if this is something you want to do, you have interest in it, find someone who will help nurture that interest and continue to build up on it. And over time, I mean, you'll learn and, you know, figure out this is really for you. And then as you continue to push through, you'll find your place.
Thank you for that. And I'll give a quick plug around how you can get engaged with us in the SNMA as your mentors for our participants at the end of this webinar. Now, if we can think back into this COVID space, into this intensity that is, you know, trying to navigate a very new pandemic for us. Yes, you can argue that we've experienced this similarly in the Spanish flu of 1918. Yes, you can argue that when we first encountered the HIV epidemic and pandemic in late 80s, early 90s, there was a similar kind of, what do we do? How do we react? Hospitals are overworked, etc. But this is new. And so I want to come to Tina's question around how you promoted wellness and teamwork within your teams in a really unprecedented time. First, I'd love to hear from you, Dr. Calderon, from a chair's perspective, how you managed to promote wellness from the top down.
Well, first of all, it's the check-ins. I mean, I needed to check in with all of my faculty, with residents, and with definitely the nurses. And that went a long way of validating their fears, because I had my own fears. There is something about making sure that you connect with people that really is helpful. Second, I found that a lot of individuals felt a sense of wellness through writing and getting their stories published. And so I supported that. It's not easy to get, perspectives published, but if you can, it was very helpful for many of the faculty. And I think also at the end, we used to have, I think almost every 2 to 3 days intervals, we would have touch points with the faculty. We would have call-ins. And so anyone could call in, ask questions. We updated. Communication is key in this area of wellness as well, when you're being assaulted in the emergency department. So those were some of the things that we did. And then certainly when we got to that lull of volume, I really encouraged everyone to take time off. Because at that point, our staffing patterns were different. And I think people needed to have that break and recharge and to come back.
Yeah, sometimes the best thing to do for yourself is to do nothing, right? To not have some wellness seminar to attend, right? Just to take that time for yourself, absolutely. I want to open the floor for other panelists. If you can speak to how your teams found resilience, some of those earlier words we touched on in my first question, how did that come to be for you? Where did you find that sense of resilience? How was wellness promoted, to Tina's question? I want to open the floor for any of our panelists here.
I think one thing that we did, I mean, it was just small stuff, but I think, like Dr. Calderon said, checking in, again, appreciating people, just letting them know that we do care, and that we are here for everyone. But at the same time, just even personally, just putting I put a little aromatherapy in my office. And what I found was that everybody kept stopping in saying like, what is that? And I was like, girl, you better get you one of these aromatherapies. Like, we up in here with lavender, baby. We're trying to get our relax on. We gave our physicians a dedicated office and lounge. Actually, it was our office. And we were just like, you know what? Everybody should have a place to escape for a few minutes and just decompress. And so that was kind of our model, just giving people a space to decompress that smells good. And, I always got some crystals around, just, with some positive vibes going. Positive messaging for the nursing staff, just saying kudos over and over again and thank you over and over again for all the work that they're putting in.
Listen, I keep a clear courts around me, okay? So we love that. And whatever that looks like for you, I think it comes to the idea of finding some sort of spiritual base in this time. If that is in the planets, if that's in religion, if that's in yoga, if ball is life, whatever that is, you have to find that for yourself. And I think you both spoke to the idea of having a time to step away and step into that in order to find wellness. I absolutely agree. So I want us to also think about your understanding of COVID, how it might have changed or evolved over this time, over this year, quite frankly, of intensity. I want to come to you, Dr. Tugo. How has your understanding of this disease process really changed? If you can think back to January 2020 you and now January 2021 you.
Yeah, I think a lot of it had to do with what was actually factual. In the beginning of the pandemic, there's so much unknown, and we were getting so much different information from different health organizations and bodies. And as a result, there's a lot of misinformation going out and a lot of distrust in health organizations and hospitals. So like overall, kind of just like understanding misinformation and understanding that people are actually comfortable when you say you don't, or you're not sure, we're trying to figure this stuff out. And then also just like knowing how to protect ourselves, how to like make sure that certain people are tested. So just like kind of like managing and kind of just like the whole awareness around COVID information and how to get that out there, how to address that. So.
Absolutely. And we can come to Dr. Annanoby. Being in a trainee space, how has your understanding of this disease process changed, especially now that you are in a critical care environment?
I would probably say, Yeah, there was a lot of misinformation. I remember as a resident, the first thing I heard a lot of my friends, non-medical friends, saying was that Black people can't get COVID. Because, initially when it first started coming out, we were just kind of seeing kind of like white people being affected, or at least saying that they had the infection. And until it hit that in our hospitals that most of my patients were brown and Black, and I had to let my friends know, I was like, no, Black people are being affected. Maybe it's not being publicized just yet, but they are being affected. So just a lot of misinformation, a lot of distrust for medicine in general, and just people thinking that this was a hoax or this was something set up by the government and things like that. And then also just kind of like the political aspect of things. And I know we're probably not going to jump into that, but definitely a lot of that from different news outlets saying that, this was either some news outlets are saying this is like the worst pandemic of the world, and other ones are just kind of saying this is not really that big of a deal. So over time, as more information was becoming available, I think people started to realize how serious this was. Even myself, I never downplayed it, but I just didn't know how serious it was until I was directly impacted through my work. I had friends in New York telling me how bad their hospitals were, how bodies were being packed into trucks. And, I was at a hospital where, we'd have 20 or 30 versus hundreds, until I moved to Miami where we had hundreds. And then I saw how severe it was. But I think the biggest thing that has changed was our understanding of how severe the infection is, but also how to decrease the severity. By now, I think the mortality has dropped significantly with the viral infection, mostly because we are learning from each other. As soon as these hospitals are putting things into practice, they're publishing it, and other hospitals are trying it. There are different medications that are being used to kind of help maybe lessen the effect of the infection. We're learning more about ventilators, about respirators, and how to oxygenate our patients, and early proning, different maneuvers that is significantly affecting how patients are affected by this virus.
Yeah, and I think that's a really important duality there, that on one hand, we have this general just fielding of misinformation over time. And then we also just have a dedicated literature base now around this disease process that I can actually type into PubMed and find something. Cheers to the academic community for sharing as widely, broadly, and enthusiastically as it has around how to approach this better. I remember some of the first case reports coming out of, even East Asia, right? About how they were doing things well and doing things right in terms of treatment. So yes, it's a really important duality. And to your point, Dr. Annanoby, no, we're not going to get into, the policy and politics around this, because that's going to be a lot of actually our next webinar coming up on the 27th around the future of health policy. So I wanted to redirect to Dr. Calderon. How has your understanding, knowledge, experience around COVID evolved in this last year or so?
So what I wanted to kind of share is what has not evolved, which is that there is an isolation that coronavirus has placed in medicine, like nothing I've ever seen. It's one thing when a patient comes into your hospital, ER, critical care, and they're dying, and you can be with them and their family to help them get through what is a very difficult time, and even cry with their family. But to have patients die with you when there's no one around, to have that kind of isolation was devastating. And I just wanted to say that, because I think that, we talk about the evolving medicine and treatments and management, all very important. But the one thing that still doesn't change is that if you have coronavirus and you come into the hospital, you're not going to be let in. Visitors are not going to be let in to be with their loved ones. We use, at least not in my hospital setting, We certainly used, phones and iPads and all of that. But I can tell you from firsthand, because I lost my father, there is nothing that calms me at all or ever will that I could not be with him in his last moments. So that's something that our community has hit hard.
Yeah. Let's stay there for a second. Let's stay there about the unspoken truths and realities of this pandemic. First, I want to thank you for your vulnerability and sharing that piece, Dr. Calderon. But as we're thinking about the things that are not as covered in the media, that we know from being in the hospital and interacting with people, that piece around updating the family, as a medical student, that was probably my most important job on my ICU rotation, was updating every single family member in our chart for every single patient in our list every single day, in ways that we wouldn't have had to had family just come into the hospital. And so I want to unpack that piece around what's unspoken about our experience. If you can think about the one thing that it seems like no one's really talking about when it comes to COVID, but that they should be, what would that be? What would that be for you, Dr. Pinckney?
One thing that they're not thinking about, I think they're thinking about that they're not going to get sick, and it drives me insane.
Okay.
And I'll just be honest with you, it's funny, I live around the corner from two pretty popular bars, and every time I drive home, I'm like, oh my gosh, like people are still out here, like, and they think they're immune, and I think it really takes, unfortunately, and this is what we don't want. This is why we're trying to educate, right? It almost takes seeing that the pain and suffering that you can probably feel from Dr. Calderon about what loss feels like and what it feels like to lose people too early, and to have to counsel people through that. And even, I've experienced the same. I've whole fell apart on Facebook Lives because, I'm also dealing with, I was dealing with a sick family member in the ICU with COVID, and people forget that. And it's really, I think, until it hits home, that piece is really hard to drive in. It's different when you see it. I mean, it's like nothing you've really seen before. But for, people who are not in healthcare and people who, aren't plugged into the news or, health platforms 24/7, they just don't see it. And I really wish we could find a better way to provide that missing piece so that they don't have to experience that type of loss.
So that's an interesting comment. The thing that we should be talking about is that the fact that some people have stopped talking about it, honestly. Yeah, I agree. And I think I similarly am carrying that stress of trying to convince people around me, people close to me, that this is a very real, current, if not worse situation. I'm in LA County right now. And so I'm quite literally in the epicenter of the world. And thinking about what were day-to-day experiences for family members even just can't be the same, but they don't see it in the way that we do. For you, Dr. Tugo, what do you think is one of the things that is not being talked about, but should be when it comes to COVID?
Yeah, kind of like echoing some of the things that were said before. I think mental health is an important issue that has been overlooked. Kind of working in the emergency department, we kind of deal with boarding of psychiatric patients all the time. You have patients that are waiting for days. However, this hasn't stopped because there's a pandemic, and it might have actually gotten worse due to social isolation, travel restrictions, not being able to see one's families and friends. So kind of like just taking that into account, and what does taking care of ourselves look like during this time in terms of like mental wellness, having grace with each other, taking advantage of different mental health care platforms or mental health platforms. So.
Yeah, and I don't even know if I've seen the same vigor around publishing stats, right, when it comes to the burden of disease, when it comes to mental illness, as we have for COVID. I think some people have certainly acknowledged that we're in the middle of if not worsening mental health crisis because of the stress of the pandemic and stress of all of the other things that have plagued our communities and society this year very publicly as well. So that's a really interesting point, that it's not just about COVID in terms of access to resources or treatment, that there's other things going on too. And we forget that some of those things might be worse because of COVID, mental health being one of them. I'll take it to you, Dr. Annanoby. what are some of the things that you think are not necessarily being talked about, but should be?
I'm gonna have to echo what both Dr. Tugo and Pinckney said. The two main things is that now that it seems like mortality seems to not be as high as it was in the past, or last year. People are not talking about it as much anymore. Before, it was everywhere you went, every channel you turned on, it talks about COVID-19, and now people are kind of starting to behave like life is normal again. And don't get me wrong, I want us to get back to normalcy, but we're not going to get there anytime soon. This virus is still alive and, still rampaging through our communities. And that's one thing that I think is not being spoken of, and as well as just the mental health and wellness of physicians and how our hospitals are being overwhelmed and how we're tired, and what we're doing to kind of stay afloat to be able to take care of the communities.
So some common themes here in terms of things that we hope you as participants can certainly leave with knowledge about. First, that if someone is in the hospital, actually not just for concerns of COVID, a lot of hospitals are just not letting people visit. I know there was a time where we were even having people who were delivering babies not be able to have their partners present as they were delivering. And so I want us to remind ourselves that if someone is affected by this, it's their entire family, not just them, to Dr. Calderon's point. To Dr. Pinckney's, that we're not back to normal. We're not, and we can't act as if we are. To Dr. Tugo's point and Dr. Annanoby's point, that you have to think about mental health as we think about physical health in this pandemic. I want to bring us to one of our closing questions now. And I would hope for us to end on a bit of a happier note. And so the question for you all is, where are you optimistic? Where are you hopeful? How are you finding joy in this time of pessimism, of darkness? And so I can come to you, Dr. Calderon. What makes you optimistic?
Well, one thing is, I mean, when I started out in research and I was doing HIV prevention, we would talk a lot about the toolbox, and that one needed to use everything in your toolbox to attack, a pandemic like HIV. And I think that now that we have monoclonal treatments, monoclonal antibody, that's, first of all, it's not talked about as much as it should be. Our communities, our vulnerable communities should know about this, because if they do get coronavirus, if they do get sick, that is a possible treatment, outpatient treatment that can be given. A lot of emergency departments are doing it now. It's an hour infusion and then an hour of observation, and then you go home and you're followed up later. But it seems to be working in terms of decreasing the amount of hospitalizations that would be needed for patients that have all the risk factors of ending up in the hospital and ending up quite sick and in the ICU. So I'm hopeful that, just as the science has been emerging so quickly and we have a vaccine out, that, that we'll turn the corner. I guess I have to be hopeful. We have to have that sense of hope and not give up. It's the resilience again.
Absolutely. Dread is okay too, but we love a dash of hopeful. Coming to you, Dr. Tugo, where are you finding optimism, hope, or joy in this time?
Yeah, I would have to say, kind of with a lot of the medical breakthroughs that have happened thus far, as stated, especially with the vaccine rollout, kind of makes me very hopeful for the future.
Absolutely. Show of hands for our panelists on here who've been vaccinated. Cheerio. To you, Dr. Pinckney, where is somewhere or something that you have found optimism and hope in?
Oh man, there's a lot of things. I mean, I know it's like crazy when you get on COVID. It gets really murky, but I mean, I look at all the process improvements that we've made, all the ways that if this were to ever happen again, to this magnitude, how prepared we'll be. Things that we didn't get right, we have an opportunity to correct once the numbers start going down. So I see a lot of hope and a lot of things I'm grateful for. Just seeing how teams and hospitals are pulling together and learning how to work together and work through challenges for the betterment of our patients has been pretty inspiring. And so I think there's a lot of really amazing things that have come out of this, and I think that we'll be better for it in the end.
Sure. And I think also to that point, how our system really evolved. You know, I never thought that I'd be on the phone or on Zoom with patients as much as I have been, but here we are, and that might be here to stay, you know? And so I think there are some changes that occurred in response that may actually be for the long-term betterment of our patients beyond COVID, absolutely. And finally, to you, Dr. Annanoby, where are you finding optimism, joy, hope in this?
Definitely in a lot of the medical advancements with the vaccine rollout. Granted, you know, there's still a lot of unknown, but I think it's very promising. And just with, you know, like I was saying earlier, with understanding of ventilators, understanding of when to intubate, when not to intubate, understanding of early treatment to offer someone the best chance of survival. Those things really bring optimism for me, as well as just like Dr. Pinckney said about the changes that have occurred just in our day-to-day movements, in our day-to-day life. Some of the things that I'm hoping will stay, just kind of like the increased kind of hand and personal hygiene that people are taking. You know, before people used to like sneeze and cough in the air. I see a lot of people now. A lot of people now are like really trying to, you know, cough in their sleeve, cough in their clothing, you know, wear a mask. A lot of restaurants have been utilizing QR codes for menus. I'm hoping that stays because I'm like touching. Sure. So just a lot of different things have changed, and I really think that some of those things I would hope would stay even after things kind of get back to normal, and that people would just kind of be respectful of you know, personal space and just making sure that, you know, keeping everyone healthy and all those things.
Sure. I might keep wearing a mask even after this is done, right? Like maybe I can avoid my typical bout of flu every year while my P's rotation, right? Maybe I can avoid that. So thank you to our panelists for your honesty and your candor tonight. You kept it real about your experience, your stress, your fear. And that's exactly what we need to see from our physicians and our leaders, especially in our participants that may carry the same fear, the same stress that we all are. And so thank you. From the bottom of my heart, thank you for being with us today. I want to offer a couple ways that you can stay involved with the Health Policy and Legislative Affairs Committee of the SNMA to our participants. First, this is one workshop and one webinar of a series. We encourage you to join us for our next one on January 27th, same time, same place, and we'll be talking about the future of health policy under our new administration, the Biden-Harris administration. Also, if you want to contact us, it's just healthpolicy@snma.org. To the point around the pipeline, we do a lot of that work in the SNMA. Yes, it's outside of the purview of the HPLA in some ways, but we have an entire pipeline mentoring institute within the SNMA that is designed to help you find those mentors, those really good pieces of information around how you can pursue this field. Our panelists and ones just like them are proud and happy to offer themselves to you as mentors. They don't join us for these webinars because they don't want to mentor you all. So by all means, contact us either at healthpolicy@snma.org or for the Pipeline Mentoring Institute, it's just PMI@snma.org as well. In a bit, we'll display a QR code. We encourage you to give us feedback about this session tonight. It's your feedback that helps us bring better webinars to you, that makes sure that we can be meeting your needs as participants in terms of information and questions. If you have more questions or comments for us, absolutely drop them in the chat. We welcome you. We welcome them. Just as this stream may stop, we still field questions on our Facebook. And so if you have questions for us at the SNMA, visit us online at snma.org or stay with us on Facebook and connect with us there. But thank you so much to our panelists for being with us tonight, and stay tuned to our participants for a QR code to give us some feedback. But thank you. Have a great evening.
All right. Bye-bye. Take care.